Hello, good morning, and a very warm welcome to everyone in the spring webinar session. It's a beautiful and a bright day outside, and we have two very exciting speakers on board. I'm Shivendra Kishore, the CEO of our Census, and also the host for today's session. The topic of the webinar is Data to Diagnosis, Whole Exome and Whole Genome Sequencing in the Patient Care. Participants who are regular at our webinar are already familiar with Dr. Alison Faber. She's first and foremost an excellent colleague, a bright and seasoned geneticist, and also the lead for our customer relationship and product management team at our Census. Our guest speaker for today is Dr. A, who is currently an associate professor and co-coordinator for genetic faculty at Gilbert and Rosemary Chagoury School of Medicine at the Lebanese American University in Lebanon. She has been a tremendous source of inspiration for many people across the world, not only for her numerous research work in the field of rare genetic disorders, particularly intellectual disability, degenerative disorders, and deafness, but also a role model, particularly for young clinical scientists to face the challenge to balance the growing regulatory concerns around patient data safety and privacy in the big genetic data field and the diagnostic odyssey of the patients. So I'm excited to see what inspirations we can draw from the speakers today to transform the lives of the patients around us in a positive way.
Yep.
So now, without any further delay, I would like to hand over the stage to the speakers. Thank you once again, everyone, for joining us.
Okay, I want to thank you as well for joining our webinar and start outlining our goals for this next hour. So I want to start by explaining when in the clinic we can suspect a patient has a genetic disease, and then we'll talk about the types of genetic tests that are available and the potential results of those tests. And then I'll hand it over to Dr. Chouery, and she will show you some really interesting cases from her practice where the genetic diagnosis really impacted patient care. I want to start with the big picture and kind of impress upon you the number of people in the world that have rare genetic disorders. And when we think about rare disease, we think about tiny little, small numbers of people, but collectively, more than 200 million people in the world are living with a rare genetic disorder. And what this means for us is that physicians of any specialty should be prepared to treat in their practice a patient with a genetic disease. So having this underlying knowledge about genetic disease and genetic testing can help you in your daily practice treating and identifying these patients. I want to talk about a few things about what I mean by that, about genetic disease and the people that we're referring to. Currently, there are more than 7,000 known rare genetic disorders, and this number grows every day as new patients are identified and new research is published. So we're still learning new things. And when I say genetic disorder, there can be three different types of underlying: monogenic, which we're going to talk about today, where one gene is causing a disease. But there's also polygenic or multifactorial diseases. This is where a number of genes can be contributing to a disease, or the interaction of those genes in the environment in a multifactorial situation. So those are diseases that are more common. We can think of autism or hypertension as being multifactorial and polygenic, but we're going to focus today on those monogenic disorders. So if we just look there, we can kind of think that about 1 in 50 people in their lifetime will be affected by a monogenic disease. So it's an enormous number, and that disease onset can be at any point in their life. Even adults can develop monogenic genetic diseases. However, generally, more than 70% of the time, these diseases arise in childhood. So when we think about having a genetic diagnosis, we can imagine, we know that that's extremely important. Having a diagnosis will impact treatment. It's essential for treatment of these patients. However, depending on the disease and the age of onset and where you live in the world, the time it takes from the symptom onset to having that genetic diagnosis can be long. In more than half of genetic disease patients, they'll have a delay in diagnosis. So they'll go more than a year without having a diagnosis. We can imagine in that time, the patients and their families are going to experience stress. There's going to be unnecessary testing and maybe unnecessary and costly treatments that we could avoid with a proper diagnosis. So I want to kind of go into that further, this value of having a genetic diagnosis. So like I was just saying, there's obvious clinical utility for the patients to have a genetic diagnosis, helping establish the appropriate management strategies and treatments when available. But we can also then anticipate disease progression and be more careful in our proactive screening for these patients and treat things earlier. And as I mentioned, having a diagnosis will allow us to minimize unnecessary, costly, and probably painful testing and trial and error of treatments. But in addition to these kind of obvious things that are benefiting the patient, these genetic test results have clinical utility for their entire families. So if we know the variant that's causing disease in a patient, then we can identify members of their family that are also at risk of carrying that variant and developing disease, or passing that variant onto their children, so then they can make informed family planning decisions. And in addition to these direct impacts, the ability to be involved in disease support groups is enormous. For these families to anticipate progression, they can get involved in trials through these support groups and really just have people to speak to who know what they're going through. It's enormously helpful for patients and their families to have this kind of support. So in order to get to a genetic diagnosis, we have to start by identifying which patients in the clinic might have a genetic disease and benefit from genetic testing. So I took this mnemonic device from Genetics and Primary Care Institute, which is 5 features to look out for in clinical practice that can suggest an underlying genetic disorder. And it's F gene. The F is maybe the most important, and it's a family history of multiple members affected by the same disease, or especially members in multiple generations affected by the same disease. This is a very good indicator of an underlying genetic condition, but it's not necessary. Genetic diseases can be new in an individual with no family history. So the next thing we would look for is groups of anomalies. This means a patient who has symptoms in multiple organs with no clear single cause. Those patients are going to be more likely to have a genetic disorder. The first E is for extreme or atypical symptoms. This can be any lab value that is much higher or lower than you would expect for a person or a person of that age. This can let you know that might be genetic. The N, neurodevelopmental delay or degeneration. So we think of neurodevelopmental delay in children, but even in adults, degeneration can be an indicator of an underlying genetic disease and should always be a red flag that should suggest genetic testing. The final E is for early onset cancers. Any cancer that is earlier than you might expect in a patient or unusual for that patient. So if we are kind of able now to think about which patients can benefit from genetic testing, we have to be able to choose the genetic test that would be appropriate. So to do that, I want to talk just for a moment about the types of variants in the genome that can cause genetic disease. So I've listed 5 really general types of variants here, from largest to smallest. So an aneuploidy is a change in the number of chromosomes. So if we think of the genome as a book, this would be an entire chapter added, so an additional chromosome, a trisomy, or removed, a monosomy. If we think a little bit smaller than that, a chromosomal rearrangement, maybe this is a part of a chromosome, so a few pages out of the book are either deleted, duplicated, or moved to a different section of the genome, so rearranged. If we think a little bit smaller than that even, we can have copy number variants. So this is just maybe a paragraph in the book or so that has been duplicated or deleted. And very similar insertions and deletions. These are just even smaller, maybe a 1 sentence that's been inserted or deleted out of the book. And finally, the smallest would be a single nucleotide variant, which is a 1-letter change in the genome that can cause disease. So the types of tests that are offered will be able to detect different types of variants, different types from this list. So I have 5. There are many types of genetic testing, but here are 5 kind of standard genetic tests that you might come across in your clinic. The first is karyotyping. This is a way to analyze the structure and number of the chromosomes. So this is kind of large scale, looking at the chromosomes generally, and this will be able to detect those aneuploidies and chromosomal rearrangements. So the really big things that are going on in the genome. A little bit smaller is a chromosomal microarray. So this is able to find those copy number variants, the very large and insertions that aren't going to be able to be detected with the karyotyping. So now we're looking on a smaller scale. Now the next three I've put in a green box because these are three types of next generation sequencing. Now, rather than looking at the chromosomes generally, like in the first two tests, we're actually sequencing the letters. We're looking at the letters of the genome. And this can be in a single gene. So here we would be able to look at those letters and detect those insertions, deletions, and single nucleotide variants in our one gene of interest. A little bit larger than that would be a multi-gene panel. And so we're looking at the letters and we're going to be able to detect insertions, deletions, and single nucleotide variants in those handfuls of genes of interest that we've chosen. And the last two I've put together are the largest type of sequencing tests. We have whole exome and whole genome sequencing. So here we're going to sequence either in the case of the exome, all of the protein coding regions of the genome, or in genome sequencing, the entire genome. We're going to look at every letter. And this will allow us to find all of the variants that I've talked about, all of the types in all of the genes. So we have 5 kind of general types of tests. When would you pick each of these is the obvious next question. So I have some kind of general indications for what types of patients you would use each of these tests for. So standard karyotyping is a very good first step in prenatal testing. So take a big look at the entire chromosome, and then from there you can choose your next test, or in the case of an aneuploidy, have a genetic diagnosis. The chromosomal microarray is a very good first test for children with developmental delays or congenital anomalies. And then, from there you could opt for a more narrow test or have a genetic diagnosis. So if we think about the next generation sequencing tests, single gene tests are very good for patients who have very clear symptoms, and most cases of those symptoms would be explained by variants in one gene. So the example I think of is cystic fibrosis, a very clear phenotype, and most cases are going to be caused by variants in CFTR. So a multi-gene panel is very good for patients who, again, have very clear symptoms, and most of the cases of those symptoms would be caused by variants in a few genes, a defined handful of genes. So for this, we can think of something like polycystic kidney disease. Again, a very specific phenotype, and most of those cases are going to be caused by a handful of genes. Now, when we think about whole exome sequencing and whole genome sequencing, these tests are going to be best for patients with a wide range of symptoms and an unclear clinical diagnosis rather than the other two NGS tests. So no matter which test you end up going with, the outcome will be one of 3 things generally. A test can be positive. This means that a variant has been detected that can explain the symptoms. Tests can be inconclusive. This means that a variant was detected, but at the moment there isn't enough evidence to know whether that variant does or does not cause disease. Or the test results can be negative. This means no variants were identified that can explain the symptoms. So what are the implications of each of these 3 when you end up with these results? So a positive test is, as we discussed at the beginning, these results will help to establish a more appropriate management strategy and anticipate disease progression. And then these results will also let us go to the family members and allow them to choose genetic testing to assess their risk of developing disease and passing variants on to their children. In a situation where the test result is inconclusive, these variants cannot be used for any clinical decision-making. And while all patients really benefit, and I would even say require genetic counseling when they get their test results, patients with inconclusive results need even more counseling, because there are some situations where family member testing could help resolve that variant. It could be enough evidence for us to determine whether it can or cannot cause disease. And in addition, it's important to remember that over time, as new evidence in the field becomes available, that report may go from inconclusive to positive or negative. So finally, a negative result, no variants were identified. So this may mean that the disease or symptoms has a non-genetic origin, but a negative result cannot rule that out, because it could also mean that the disease-causing gene may not yet be established in the field. And as more information becomes available generally, we may be able to find a genetic cause for disease. So when we think about that and the inconclusive test results, it really highlights the importance of over time reevaluating these sequencing data with all of the new information available for patients to end up finding this genetic diagnosis, getting a positive result as soon as we can. So with that, I am going to hand this over to Dr. Chouery so she can show you her very interesting patient case studies that have benefited from genetic testing.
Thank you, Alison. Thank you so much for this very nice, concise, precise presentation. Good morning, everyone. I would like first to thank the organizer of this webinar for inviting me, as well as the fantastic team. And finally, of course, I would like to thank everyone joining us online for your time and also for your day to ensure a better quality of life for patients affected with rare disease. So today I will share with you the stories of the genetic diagnosis of 5 patients. But I believe that in our daily practice, each patient has his unique story, and each story hides a different and important message. So, in this case, a 6-month-old boy referred to our department for genetic diagnosis. He presented with several concerning symptoms, including hypotonia, spasticity, which means stiffness and involuntary muscle contractions, hepato and splenomegaly, and seizures. We all agree that these manifestations suggest a complex medical condition which requires a thorough evaluation in order to take the necessary steps for clinical management. Regarding the family history, the parents were related and they had, unfortunately, 2 previous children that diseased at just 1 year of age, which pinpoints towards a severe genetic disorder in this family. So, exome sequencing was performed in the patient, and the results showed that the patient was for 2 different pathogenic variants. One pathogenic variant in the PIGN gene, and one likely pathogenic variant in the TBM1 gene, please. So, we know that the PIGN gene is involved in a syndrome that is called multiple congenital anomalies, hypotonia seizure syndrome 1, and that the TBM1 gene is involved in congenital disorder of glycosylation type 1E. The PIGN syndrome includes neonatal hypotonia, lack of psychomotor development, seizures, dysmorphic features, and variable congenital anomalies. While the TBM1 gene, it will lead to severe mental and psychomotor retardation, hypotonia, seizures, and hepatosplenomegaly. So which one of these variants, in your opinion, is the variant that is involved in the disease of the patient? In fact, combined both together, both results, they can explain the observed symptom in the child. So this story highlights an important, which is a possibility of co-occurrence of multiple genetic disorders in a single patient. And this is very important in the countries where we do have a high rate of consanguinity. And trust me, this is not the first or the only case we have in our database, while a patient affected with genetic disease presents with more than one condition. So, the lesson learned from case 1 is that 2 diseases can occur in one patient. So that's why it's very important when you're doing the exome analysis or whole genome analysis of the data of a patient, not just only to look for a panel of genes, but please have an open-wide look and try to do the analysis of the entire gene that you have. Case 2. So in this case, this case involves a 2-year-old boy presenting with symptoms of infantile nephronophthisis, which is characterized by inflammation and fibrosis of kidneys that can lead unfortunately, to end-stage renal disease. The family history indicates that the parents were not related. And we performed exome sequencing for this child, and the results revealed the presence of a heterozygous variant in a gene called NEC8 gene. Why? What is known about this NEC8 gene? We know that NEC8 is known to be associated with two different autosomal recessive types of nephropathies, which are conditions affecting the kidneys and inherited in a recessive manner. We tried to sequence again the entire gene, the NEC8, and we didn't find any other mutation in this gene. So the patient was only heterozygous for only one variant. And as mentioned above, as you can see, the variant was tested in the parents and it was found to be de novo, which means that this genetic variant occurred by accident in the child and was not inherited from the parents. So this was an unusual discovery because NEC8 is related to autosomal recessive diseases. Here we have just only one mutation. So this unusual discovery of a heterozygous de novo variant in the NEC8 gene encouraged us to consider publishing this finding. And the paper was published in April 2023 by our team, reporting only one patient. So we were quiet about our finding, but we needed a confirmation. That's why the paper, as you can see, it was published under a big question. NEC8 associated nephropathies. Do autosomal dominance exist? And the confirmation came 6 months later, where a collective work between different teams reported 12 additional families with similar findings. So what was interesting is that the mutation that we published was reported by, was found actually in 10 out of the 12 reported families in this paper. So the lesson learned from case 2 is that atypical findings do indeed exist, and reporting them is really essential and is very important. So this case underscores the importance of reporting unusual or unexpected genetic discoveries within the medical community to advance our understanding of genetic disorders and enhance patient care. Let's start the case 3. So in this case, we have a 2-month-old boy who was referred to our clinic seeking genetic diagnosis. He presented with congenital cataract. So exome sequencing was performed on this child, and it revealed the underlying cause of cataract. So actually, we found a pathogenic variant in the MAF gene that is involved in a type of cataract called cataract 21 multiple types. Surprisingly, another pathogenic mutation in PMS2 gene was also detected. We detected a deletion of 4 exons in the PMS2 gene in the child. This mutation suggests a predisposition to Lynch syndrome, a hereditary cancer, as you know, syndrome that is associated with an increased risk of cancer, resulting in colorectal cancer. So, following this result, the next step was, of course, to do further investigations in the families that showed that the father has been experiencing symptoms of blood in his stool over the past 3 months. So this suggests that the father might have maybe colorectal cancer or other intestinal condition. So that's why immediate medical attention is needed, as well as genetic testing to check if the PMS2 deletion is present in the family members too. In summary, the genetic finding in this child not only provide an explanation for the congenital cataract, but also it alerts to the possibility of inherited cancer predisposition syndrome in the family. So the lesson learned from case 3, genetic result extends beyond the single patient to include the entire family, potentially revealing, but hopefully treatable disease. let's move right now to the fourth case. So in this case, we had a 1-week-old girl. She was suffering from uncontrollable diarrhea. The diarrhea started on the first day of life, and the girl was admitted to the NICU. So the parents were consanguineous, and the exome sequencing was performed, and it revealed a homozygous variant in the SLC5A1 gene. So it is known that homozygous or compound heterozygous variants in this gene, they are known to cause glucose and galactose malabsorption. This genetic finding provides actually a clear explanation for the severe uncontrollable diarrhea in the child, because indeed, if you have a glucose galactose malabsorption, which is a rare autosomal recessive disorder, it will lead to an inability to absorb glucose and the galactose in the small intestine, leading to diarrhea upon ingestion of these sugars. So the disorder manifests within the first weeks of life, and the severe diarrhea and dehydration are lethal unless glucose and galactose are eliminated from the diet. If this disease is diagnosed and treated properly, as you can see, patients can fully recover and they show normal growth and development. Lesson learned from case 4 is the following. Understanding the genetic cause of the disease, it opens doors to potential targeted therapies and novel treatment approaches. And now we move to the last case, case 5. Here we have a boy, a 6-year-old boy, and the reported symptoms in this case include recurrent otitis, pneumonia, fever, hepatosplenomegaly, neurodevelopmental disorder, congenital hearing loss. The parents, they were consanguineous. Additionally, they had 3 siblings with the same clinical presentation as the 6-year-old boy that have unfortunately passed away at the age of 3 and 5 years old. Exome sequencing results revealed for the first, when we've done the first analysis, it was negative. However, we've done further analysis, or what we call open exome analysis, which means that we didn't stick to the 5,000 genes that are known in literature that are linked to genetic diseases. When we do open exome analysis, this means that we do the analysis of the 20,000 genes that we know and that they are present in our genome. So further analysis of the data that we have from the exome sequencing allowed us to identify the presence, or to identify the homozygous mutation in a candidate gene. It was candidate at that time, which means that the function of this gene was very interesting for us. It is called poly3. It is a DNA polymerase, and this gene was never linked to any disease before. Of course, we've done additional genetic testing in the brain. Of course, we've done more additional functional studies like Western blot or other analysis. And we confirmed the pathogenicity of this mutation and its implication in the disease. And this was actually, after information, these results were published. So the lesson learned from case 5 is that new genes are still waiting to be identified, and the concept of analysis holds significant value. Note, analyzing the entire exome was still till today our strategy. So as mentioned, instead of sticking to the 5,000 genes that are already involved in diseases, we do the analysis of 50,000 genes, because we do try to identify new genes. So we were doing exome analysis till a few months, and now we are considering shifting to genome sequence. Indeed, actually, because of the decrease of the cost of NGS and the increasing importance of data, make genome sequencing now an interesting option. And also, as mentioned by Alison, when you do genome sequencing, it's also beneficial because also you can see structural variants as large deletions, chromosomal rearrangement, which sometimes may be missed by exome sequencing. In summary, so rare genetic diseases are collectively common, and a physician in any specialty can expect to see a patient with a disease that has an underlying genetic cause. So actually, we do talk about rare diseases, and we say that rare diseases are rather collectively and altogether, they are not rare at all. They are common. That's why we do have to continue doing research and to try to identify and link more genes to these diseases, because in this way we can find a specific treatment for a genetic disease. Yes, second, the genetic variants belong to the entire family, not only the index. And this was shown with a patient where we identified a deletion with the PMS2 in the PMS2 gene. So when you have a mutation that can involve other members in the family, this is our role to contact the entire family and to try to see who is carrier of these variants. Then the field of genetics is constantly evolving, and each case contributes to collective knowledge. This is very important, and this was shown also in the last case where we identified a new gene and we are still working on identifying other genes. Re-evaluation is possible and can turn negative report positive. This is very important. So I always keep explaining for the physicians here in Lebanon, when you do exome sequencing or whole genome sequencing for a patient, please, you have to keep the data. So this data can be reanalyzed 1 year or 2 months or 2 years after, actually, because sometimes we do identify new genes, we go back and we identify and we do the reanalysis again of the data. And also sometimes you do have more clinical features in the patient. So that's why it's important to go and to re-evaluate the data from the West or from the genome sequencing. Yes, and a genetic diagnosis is essential in managing the care of genetic disease patients. So this was also shown in the patient who was suffering from diarrhea. So once we had the mutation in the gene, we directly had the option to have a treatment. So this is a very important message too, and we hope that all genetic diseases will be treated one day. Thank you all. Thank you for listening.
Thank you, both of you. It was very insightful, at least for me, that I took a lot of take-home messages from there. Now the stage is open for questions. I think the first question is more directed to Dr. Eliane. So the question is about the case 1. I think this was the DPM1 and the PIGN gene.
Yeah.
The question is, how combining 2 different variants from 2 different genes can cause the disease? Are the genes interacting with each other? Did you validate or did you do validation studies? Because
So in this case, because the family was consanguineous, so the parents, they are related, and we had this patient present with different syndromes. And for the physician, they were not able to identify the syndrome without doing genetic analysis. In this case, we performed exome sequencing, and surprisingly, we found 2 variants that were pathogenic in 2 different genes, mentioned by Alison. So usually when you are sequencing, either you will go and find a variant that is pathogenic, or you will not find anything, so the result will be negative, or you will find something that is still now not we don't understand it very well. These are variants that are called variants of certain significance. So in our case, 2 variants were identified and they were known as pathogenic in 2 different genes. So one gene can cause hypotonia, severe psychomotor delay, hepatosplenomegaly, etc. And the other gene also can cause other findings, other clinical signs. So combined together, the patient actually was suffering from both diseases. And what we noticed also that the gene DPM1 that actually is involved in the hepato and splenomegaly. Usually, the hepato and splenomegaly are not noticed until a certain age. In our child, it was in the child or in the patients that we were investigating, we had the hepatosplenomegaly starting early age. Maybe the combination of the two syndromes, they make the syndrome worse. So that's a story. So I don't know if I was clear enough.
Yeah, thank you. There is another question more related to the technical side between exome and genome. Is it possible that one could find a variant in exome but is missed by whole genome?
Vice versa. Yeah, vice versa. So sometimes we have a variant that we identify in exome sequencing that we miss in genome sequencing, and also vice versa. So we can have it in the genome a variant that we miss in the exome. All is related to the coverage that we have. But I assume that doing whole genome sequencing, the whole genome should be well covered and covered enough. And now also with the exome sequencing, we have good coverage. So we should not miss exonic variants unless the region is difficult to sequence. But yes, we can miss a variant in exome and find it in the genome or vice versa. That's why it's important when you see that for the technical part, if you're not 100% sure of the presence of this variant because of the death, for example, the better is to go and to sequence, to do longer sequencing confirm.
In this context, Dr. Eliane, what would be your recommendation for doing an exome or a genome as a first line? So how do you decide for your patients when you're going for VEST, knowing that sometimes you could miss a variant in either of these tests?
Yeah, exactly. So actually, depending on what we are searching for, if we are suspecting large deletions, large rearrangements, I would prefer to go and do whole genome sequencing nowadays. Before we are doing karyotyping, microarray analysis. So today, still, since we have access to whole genome sequencing and since the cost is decreasing, so we do prefer to do whole genome sequencing. So in this we can see large rearrangement, and at the same time, you can see also the single nucleotide variants. However, if I have another, let's say, another case where I do suspect something like point mutations, and because the cost of the whole genome is still a little bit higher nowadays, so I will go for some sequencing.
And one question also related in this whole context, when you mentioned before, was the reanalysis and the value of revisiting the data of exome and genome. What would be your estimate, or what should a patient expect? At what time point when a patient comes back to you for reanalysis, what would be the expected diagnostic yield when somebody visits or revisits the data after a specific period?
Okay. Actually, we published a paper in 2020 where actually we had our results for 5 years because we started doing exome sequencing in 2015. And in 2020, we've done the reanalysis of our data, and the yield increases from around 44% to 56%. So, and this actually was related to the fact that more genes were identified, because also we had more experience in doing the analysis from our side. And the other point, because of in the patient, we had more clinical signs. So when you have clinical signs, the analysis will also different. So the yield actually increased. What we do actually recommend now for the patients is to come back 2 years after and with reanalysis of the data. Sometimes we find, sometimes we don't find.
You mentioned, Dr. Eliane, this is a question from my side, because you mentioned a very interesting number from 4% to 56%. Is it based on the disease category, or how is the range being changed?
Yeah, a very good question. Actually, for example, I can tell you for deafness and for a problem in the eye, ophthalmo, the rate was like 100%. For the neurodevelopmental disorders, so we didn't go up much more. You know, these are very complex neurodevelopmental disorders. And for metabolic disorders, we went like 2% more. But yes, I agree that for autism, neurodevelopmental disorder, it is still very difficult to raise the yield.
There is one question, I don't know if I understand it correctly, but the question talks about dominant diseases. Usually we see a variant in the proband that was inherited from one of the parents, and there is a high clinical suspicion that the variant could cause the disease. The proband shows some symptoms, but the patients are symptom-free. How would you explain the discrepancy? Perhaps because of penetrance, but I leave the question to you.
Yeah, actually, the first thing that will come to me in mind, I will say incomplete penetrance. Or also, so incomplete penetrance, so sometimes we don't know why till today. Sometimes we have a mutation in the father, for example, that is causing the disease, and then one of the child has the same mutation and he doesn't have the disease. First of all, we have maybe to still wait. Maybe the disease will appear later, not it's of early. We have to see if the disease is of early onset or not. This is first. And second, they do have incomplete penetrance, so they will stay, the child will stay disease-free all his life, and this is related to incomplete penetrance. And we don't know if incomplete penetrance is related to other variants that are present in our genome that are protecting or that are doing another effect for this gene to not be expressed and to not cause disease. That's why it's important now, all of us, we shift to genome sequencing. So we will have a lot of data of our genome, and so we can do the analysis and try to understand more our genome.
There is one very broad question. Perhaps you could talk hours on it. What is the future direction for genetic testing?
The future, so I hope from my that one day we have one test, and I think it will be coming with the whole genome sequencing and the long read ones, because if we have this only one machine that can detect in the same time single nucleotide variants, rearrangement, methylation problem, and 3 nucleotide repeats in the same time, so this will be heaven for us. So one machine doing all of these. So we are a little bit, we are like near, no, I hope that near will be having this solution. And also now, because of the AI, we have the AI now. So even for the analysis, we will have softwares that are very sophisticated that can do the analysis of the genome in like minutes and will all the results. So I can see it coming. So this will be the future. But for the moment, we are still, it is a little bit difficult to choose, so depending on the clinical actual presentation, and as it was mentioned by Alison, so we still have all of these tests. We have to pick the right test and to do it for the patient. Of course, whole genome sequencing now will be the best, covering large rearrangement and also single nucleotide variants.
Thank you. Alison, would you have a different take than that, or something that you'd like to add here?
I agree. Everything, the technical advances are going to make the variants that we can detect, as she said, better and better, and the interpretation of the variants will get better. But I just wanted to point out and reiterate what she had said in her case studies was the research also needs to keep up with these technical advances. If we don't have publications linking patients and variants to disease, then no amount of AI and variant detection will get us to those positive reports. So we really need to focus on that research. That's all I would add.
Absolutely. Thank you.
I agree.
If I don't see, in the interest of time, I think we should close the session now. So I would like to thank both the speakers. I would like to thank also the participants for taking the time off for this interesting and very enlightening webinar. Thank you, everyone, and wishing you a nice day ahead. Bye-bye.